Good morning, everyone. My name is Amy Murphy. I'm a brain injury medicine specialist here in Alaska. And I want to just emphasize how important it was for the first piece of this morning, knowing the community resources that are out there. That is the biggest piece of the treatment for brain injury, not only in this state but everywhere, much bigger than just any individual piece that I may have or any individual clinician can have. And so just being aware of what's out there and making sure that that education gets out to consumers, providers, and and family members, anyone who is involved in the care or living day-to-day of brain injury surviving. That is the biggest piece of this puzzle. And so I'm very, very grateful for the speakers that were able to come in. And I'm very grateful that you guys are here on this beautiful rainy weekend in Alaska. So I'm going to talk a little bit about traumatic brain injury. The biggest thing that I would like to put out today and get out are a couple things, one of which is the screening tools that we're introducing. Tara had mentioned them briefly. We are going to be using them through the behavioral health aid as well as the health aids through the Native Corporation. But I've also worked with DHHS on making sure that these are, because they're validated screening tools that are available through the state as well. And I've been really trying to get these out to other providers, pretty much anyone in the community, because these are things that we can use to help identify and make sure that people are getting referred into services, because you can't get the services if you haven't been identified as having a brain injury. So that's one thing. The other thing is to know what resources that we have out there specifically for Alaska, as well as to know that there are treatments available for various symptoms, conditions that can occur after brain injury. And I've had a lot of people come in and tell me, I was just told this is how it's going to be, you're just going to have to live with it. And that's actually not the case. There's a lot of new research that's coming out. There's still a lot we don't know, but I at least want to be able to present you guys with what we have at the current time. So that being said, we can go ahead and get started. I'm just going to cover I want to cover the entire range of brain injury so that you can kind of be aware as far as the severity range. Now we're going to focus a lot on concussion management or mild TBI here, but also to know kind of the differences between the more moderate and severe brain injuries as well. Because I've had some people misdiagnosed who had moderate injuries that were just diagnosed as a concussion, and so it's important to know where the line is drawn for these individuals. We're going to talk a little bit about anatomy and physiology. Not much. It's Saturday morning. We're going to talk about imaging because that's kind of like a hot topic in brain injury, especially with mild brain injury, because traditional imaging from the past, we weren't really able to identify anything structurally. We do have some things on the horizon that are able to show us a little bit more. And so we can discuss that. As well as management and treatment. And then, of course, I'm going to be discussing the screening tools as well. So, TBI is an insult to the brain. So when we're looking at, and when it says not congenital, that's an important distinction to make a lot of times as far as funding streams for the state. So if you're born with it, it's something a little bit different as far as funding streams than if it's something that you received after you were born. But we do recognize that there's a degenerative nature to the symptoms that occur after a head injury. And it can be something very mild to something very severe. But we typically see impairment of cognitive and or physical capabilities. They can be either temporary or permanent, and they can cause anything from partial to total disability. So there is a wide realm of what you can experience after each level of brain injury. The Center for Disease Control lists any occurrence of injury to the head that is documented in the medical record with one of the following conditions. It does not need to be a full loss of consciousness. Altered states of consciousness, kind of like feeling like you had your bell rung, seeing stars, that momentary period of confusion where you just kind of feel out of it. That is an altered state of consciousness. You do not need a full loss of consciousness to be diagnosed with a TBI. The other piece of it is you do not have to have a direct blow to the head. It has to be forces going through the head. So this is important when you think about motor vehicle accidents, because a lot of the times with people wearing seat belts, you have also, any anti-impact device within the car, you may not have a direct blow to the head, but the movements of force from the acceleration and deceleration of a sudden stop with an accident, that is a force going through the brain. So you do not need a direct blow to the head in order to be diagnosed with a mild TBI. You may or may not have some period of amnesia. There are people that have brain injury that they absolutely have a period of time surrounding the event that they just don't get back. And that is pretty common. You may or may not have any fractures to the skull, and you may or may not observe any neurologic or neuropsychological abnormality. Some people get concussions and they completely resolve. Some people get concussions and they have continued symptoms. More moderate and severe brain injuries, you definitely observe some type of neurologic signs or symptoms whenever they're coming in. Brain injury is a big deal in the country, and these are old numbers. I think these are from 2005 maybe, but when we're looking at the amount of emergency department visits, we estimate that 3 to 5 times more than that have mild traumatic brain injury that never seek medical care. So that's a huge number. Hospitalizations are also fairly high, and when you look at the number of deaths, that's when we're looking at the more severe brain injuries. When you take a look at the pie, when you think about all of the kind of media-driven kind of resources that you're looking at for other conditions, multiple sclerosis, you can see the piece of the pie, spinal cord injury, HIV, breast cancer. In relationship to brain injury, those are still relatively small, yet it's only been recently that we've had this huge emphasis on brain injury, and that's in large part due to the NFL Players Association that we've really started to get more awareness around brain injury in this country. And reasons why. Again, there are a lot of different reasons, and of course that can vary from state to state. Domestic violence up here is really pretty high. We have a lot of snow machine accidents. We have a lot of falls up here on the ice. But when you look, falls, motor vehicle accidents, assault, those are still pretty high numbers. And then of course we always talk about prevention because interestingly enough, although we have no reason to understand why, people who have sustained a head injury are more likely to sustain another head injury versus somebody who had never had one. There are a lot of theories about why that would be the case. So in more severe head injuries, well, is it the impulsivity that's causing that? Are we just looking because this is a population that's more at risk for that anyway? Are we looking at mild brain injury because there are slight balance issues that have never been really addressed and that's leading to an increased incidence? We really don't know. But what we do know is if you have a head injury, you have a higher risk of having another one. And so educating on prevention is a huge deal whenever anybody comes in to my office, and also something to just be aware of. Helmets. Every kid in my neighborhood now, when they see me, they're like, when I first moved in, they were like. So mild traumatic brain injury, also known as a concussion, you're looking at a loss of consciousness less than 30 minutes. You're looking at post-traumatic amnesia time of less than 24 hours. Typically, there's some type of altered mental status at the time of the accident, even if it's just a brief feeling like you saw stars. Typically, you don't see any neurologic deficits by the time somebody would present to the emergency room. There are no operative lesions, but you can have a lot of symptoms coming in. Nausea, vomiting, dizziness, headache. Headache's one of the biggest ones to really look for, and we'll cover this a little bit more when we look at the Rivermead scale. But there are some disturbing facts that have come out of some of the research we've done following people long-term after concussion. Things such as, in Canada, when they were following people years after who presented to the ER, if they had vomiting, they were 1.5 times more likely to not have a return to work at a year. That's an important thing to know. And so if you have somebody presenting that has had vomiting after their head injury, that's somebody that should be seeking more aggressive treatment sooner rather than later. The severity of the symptoms when somebody presents, also we found, has been, really recorded, and that's why we use the Rivermead, because if you have a quote-unquote positive Rivermead, then they were 3 times more likely to develop post-concussive syndrome. And so these are also patients we want to early identify and get into treatment sooner rather than later. Because the old thinking was that the majority of people that have a concussion are going to just naturally get better. But now we're realizing, based on presentation, that may not necessarily be the case. And we may be able to identify people and definitely get them into the treatments that they need so that they don't develop it in the future. You can definitely have cognitive deficits after a mild traumatic brain injury. And anybody who's sustained one knows this. And these are things, again, that traditionally were thought, well, these should just get better with time. And if these continue, well, we just don't think it's from the brain injury. And now from recent research, we know that is not necessarily the case. You can have continued cognitive deficits after a concussion and know that the source of it was the concussion. And behavioral changes. Part of a big pet peeve of mine, one of them, is when I'll see write-ups, especially from independent medical providers who are working for insurance companies, who say that, oh, well, this is definitely not from their concussion. They have a mood disorder. I'm like, okay. But they didn't have one before the concussion. So the mood disorder, what they're feeling, this is from the concussion. We know that this is part of the syndrome that can occur. And so a lot of the times I have people that come through me through the Behavioral Health Network because they were, it's very common for, emotional lability, irritability. Those are things that family members and patients pick up. And so they're put into the system for treatment, and then that's kind of how they come in through the back door as far as getting the care for the original injury, which was the concussion. A moderate traumatic brain injury, you're looking at a loss of consciousness greater than 30 minutes. However, it's less than 24 hours. So now you're starting to see the cutoff times. The Glasgow Coma Scale is typically normal in people with mild traumatic brain injury. It's 9 to 12 in those with a moderate brain injury. Another thing I've noticed, you don't necessarily always see that documented in ER visits whenever I have somebody coming to see me. So a lot of the times we're looking at somebody's personal history of either loss of consciousness or post-traumatic amnesia. And loss of consciousness can be tricky, right? Because if you're alone, how do you know how long you lost consciousness? Not too many people look at the clock right before they lose consciousness, look at it right after they get back and say, well, I know it was definitely 32 minutes. And so it can be, you can have, there's a gray line there. The same with post-traumatic amnesia. Because if they come in and they're agitated and then they get sedated in the hospital, well, how long was their post-traumatic amnesia going to last naturally versus how long is it now lasting because they have medications on board that are meant to keep them sedated so that they don't provide any further harm to themselves or others. Many of the times you'll have some type of imaging finding, some type of bleeds in the brain, but not always. I do have those individuals, and these are the ones that typically get misdiagnosed, that their original CT was fine. They come in, they're diagnosed with a concussion, but then when you get their history and you look at their post-traumatic amnesia, it was actually longer, and they actually had a moderate brain injury, which fully explains why they're having the severity of continued symptoms that they're coming in with versus somebody with a concussion. And then severe. So this is somebody with greater than 24 hours of loss of consciousness or greater than 7 days of post-traumatic amnesia. And there are a lot of different variations within this line. You can have some people that, on day 8, they're fine. You can have some people that remain in a coma or a vegetative or a persistent vegetative state for some time. And so when we're looking at severe brain injury, the length of the post-traumatic amnesia typically tells us long-term how severe their continued symptoms are going to be. So we have primary injuries that they occur at a specific point in the brain. So you have a specific lobe that has been damaged. And then we also can have diffuse injuries, and especially what we call diffuse axonal injury, which because of forces mean that there's been a stretching or rotational force that has occurred within the brain that has caused kind of like this diffuse injury to all of the axons in the brain, and these individuals typically have poor outcomes. And that's important to remember when we think about concussion, because in more severe injuries, you can definitely see the diffuse axonal injury on their imaging. However, it's postulated that there's some form of that with even some of these mild traumatic brain injuries, which are why people aren't healing as we think they should, based on old thought processes. So bricks to the head are never good, as you can see from the picture. But we're looking at a focal or primary injury. You can also get these with any type of direct blow, and you can get it, of course, to the primary area, which is where you hit, and then on the opposite area due to the coup and contra coup injuries. Baseball bats also are not good. And so you can get contusions, you can get actual bruising of the brain, and we see this really well in imaging, and that's basically what it looks like. And then with concussion, you can have deformity. Basically what we're finding is it's more of a deformity of the deep brain structures. And when we say that, an understanding of kind of how we have evolved is important, because the deep brain is the oldest part of our brain. This is kind of like our caveman brain. It's kind of what keeps us alive. So we have our sympathetic and parasympathetic higher order nervous system inputs in here, which basically tell us, big, big bear, run away. But then when it gets altered, it can be something that is really not going to cause us any harm, yet our body responds like it's a big, big bear, run away. We have our emotional centers in there, which is why we can see a lot of emotional disruption. We have some of our memory centers in there. A lot of our input centers that kind of work as the main relays to get information in and out of the brain run through there. So the deep white matter, when it's disrupted, creates a lot of widespread symptoms that really can be accounted for when you hear the histories and you're familiar with what that looks like, but can sometimes, I'll have people come in and say, I just thought I was just going crazy. I could not understand why this stuff was going on. I'm like, well, that's pretty par for the course when you're looking at deep white matter injuries that can occur with concussion. And again, like we mentioned, the diffuse axonal injury. Now, as we're doing more and more studies, we're noticing that, yes, there is some component of mild diffuse axonal injury in some of these high-velocity cases. And that may be accounting for why we're seeing more and more numbers of people and identifying more and more numbers of people that are having post-concussive syndrome and continued symptoms, because we know historically diffuse axonal injury does cause more severe symptoms than when it's not present. Again, another focal injury, epidural hematoma, subdural hematoma, Subarachnoid Hematoma. So typically when you see the three of these together in one person, you know it's due to trauma. And this is important, especially in the younger population, because then if you have a kid coming in, that's typically kind of your concern to look for some type of trauma occurring. So if you get a history that there was no trauma, then it bumps up your instincts for, is this a non-accidental trauma? And then, of course, I showed you the picture of the intracerebral hematoma. This is kind of what we can see, especially when it's more significant on a CT scan. In intraventricular hemorrhage, the ventricles, basically when they get blood in them, it can lead to a lot of long-term outcomes too, so that's another thing that we're looking for. And when I mentioned, the deaths due to brain injury, a lot of times that occurs because of brain herniation. Our brains are basically kind of like, the consistency of scrambled eggs within a hard environment that have these different membranes that go through. And if you're starting to have brain swelling and it pushes a piece of the brain through or around one of those membranes, that can result in a herniation. And typically that can result in death. So it's very important to quickly identify some of the more severe brain injuries and make sure they get in, because that's when you have neurosurgical intervention that is needed so that the swelling does not cause any type of herniation. But basically, what I want to, again, repeat is the centripetal model is what we're looking for in diffuse axonal injury. We're talking about the shear forces that occur with rapid acceleration with deceleration, as well as some rotational component. And we're seeing these in car accidents, but the biggest thing that has driven the research, of course, have been the sports injuries. And so we know that these forces come in or are translated into the brain based on some of the new helmets that we've been using for the football players, where it's actually able to identify the G forces that are coming in and determine if they're more linear, more rotational, and that's what's led to a lot of the research behind this. And then you can have secondary brain injury. You know, you can have the herniation, as we talked about. Hydrocephalus can occur whenever there's any bleeds into, you know, any intraventricular bleeds. You can have the edema, you can have ischemia, and then of course conditions that can exacerbate that are things that we're really looking for within the ICU setting. And I will tell you that neurosurgery has done a fantastic job of identifying the different resources and the different interventions that they need to do in that golden first few hours to make sure that people are able to live through some of these more severe injuries, because that was not the case about 15 years ago. And so they're really able to go in, they're able to make sure that people are able to survive these more significant injuries. But what that means from our end is that these people are now surviving, and we need to not only, you know, for me it's more of a term of survival, but also a chance of getting back to life. And there are a lot of things that can cause cerebral edema. And so these are some of the things that we're looking at in the initial ICU course to make sure that either it doesn't happen or we are reversing it in time so that there aren't poor outcomes. So typically you get the insult, you get edema, intracranial pressure can increase, which can lead for concern for herniation with compression of blood flow. And then, of course, oxygen doesn't get to the brain, so you can have cellular death. And then whenever the cells die, you get even more edema around that area. So you can see how this pattern, at any given level, you can come in and basically provide an intervention so that it doesn't continue along that cascade. Who's heard of Phineas Gage? So it was, I think back in the 1800s or early 1900s, this was a gentleman who was working on the railroads and an explosion went off and one of the spikes went up through and basically went through his frontal lobe. He survived, he was fine, but he just wasn't the nice person that he was before it happened. And that lasted even after, you know, the thought of, wow, I just had a spike go through my brain. But the frontal lobe definitely deals a lot with emotion and emotional lability, as well as social behaviors and personality. And so damage to the frontal lobe can lead to a lot of the things that we notice in patients, especially in more severe patients who they're impulsive, but more importantly, they don't understand the things they cannot do. And so when you're talking to someone, they're like, I could totally drive a car. Probably not. Or my one guy who's like, no, I know I shouldn't drive. So what are you doing this weekend? Well, I'm taking a helicopter flight course. And I'm like, if you can't drive a car, do you think maybe you shouldn't try to fly a helicopter? And that the equal sign just never came in. And so these are some of the things you can see with the frontal lobe. Of course, you can have the motor cortex there as well. So depending on where it falls, you can also have paralysis. You can also get an expressive aphasia where they just can't get the words out. But definitely, when you think frontal lobe, you think more of the behavioral piece of it, the emotional piece of it. The parietal lobe, and people laugh, I'm like, if I'm going to lose one of them, I guess I could lose the parietal lobe, because you know what? I'm not really that great with calculations anyway. My perception of kind of like visuospatial perception isn't that hot. Inability to focus visual attention. I'm not a visual learner anyway. You know, hand-eye coordination. There's a reason I don't do sports. And so, but you know, typically parietal lobe lesions, you will find people coming in. They're a lot more functional than previous. But you still have, difficulty with finding words, anomia, difficulty with left-right confusion, calculations, and so forth. Apraxia, in more significant cases, these are the people where you say, show me how you brush your teeth, and they just can't pantomime how they would brush their teeth. The occipital lobe, this is where we get into more of the visual piece, visual illusions, difficulty with recognizing objects or locating objects in an environment. I don't know how many people have read the book, The Man Who Mistook His Wife for a Hat. That is an excellent book. Oliver Sacks is a fantastic clinician. I recommend all of his books, but that one particularly really shows some of the deficits that people can kind of live with and live through after having significant types of trauma and lesions in the brain. And the temporal lobes, so the ability to recognize faces. You can get Wernicke's aphasia, where just people are talking and talking, but nothing that they say makes sense, similar to politicians. And so you're like, I understand that sounds like English, but together it just doesn't really equate to much. Short and long-term interest, memory issues, decreased interest in sex. The big thing with the temporal lobe, too, is that lesions in this area typically lead to problems with seizure disorders. And so we're always looking at temporal lobe injuries as kind of a potential for a seizure focus in the future. And then the brainstem itself, another old part of the brain, where a lot of our vital drives come from, our respiratory drive. And so you can have some significant issues if you have brainstem damage, difficulties with swallowing. Vertigo is a big thing after brainstem, sleep apnea, insomnia, as well as some endocrine abnormalities. And the cerebellum, which is that cauliflower-looking thing on the back of the brain, it actually does some pretty important stuff. That's our higher coordination center and balance center. It allows us to reach out and grasp things, even especially with fine motor. You can see people that come in with a tremor, again, vertigo, as well as difficulty with performing rapid movements.